Hello, everyone, and welcome to the July session of the K&K Q&A. That kind of goes together, Cindy. Cindy Kraft is on with me today, and we have a bunch of questions, and some that were pre-submitted and some that have arisen in the last couple months. But I want to remind you that if you have any questions that come to mind while we're talking today, or any that you forgot to pre-submit, please feel free to put them in the Q&A, and we will get to as many as time can permit. Cindy, how are you today?
Pretty good. I want to apologize in advance if there's any background noise. I've picked the quietest spot I can, but I'm having some work done and they sometimes end up right outside my window. So I'm working to minimize it, but I just want to put a disclaimer on today just in case.
I completely understand. The first thing I wanted to talk about is that you have some information that you want to share with folks about the ending of the public health emergency, and that was a discussion point on one of your committee calls with NOC. What is it that you wanted to talk about, Cindy, and give people this information about since it's hot off the presses?
Well, before our attendees have, may have skipped a heartbeat when you said end of the PHE, we don't have some insider information that it's ending. The discussion really was that all indicators are we will get another extension because it was supposed to end this month, but we have always been told along the way that the extensions are in 90 days and that we're supposed to get 60 days notice before any decision to not continue. So we have time to prepare. But what was interesting is there has been some discussion from CMS about it may not be like all home health waivers end on the same day. They may phase some of these things out. Now, there's no indicator that they will for sure do that or which ones they mean by that, but it's caused an uptick in the discussion about our agencies even thinking about preparing for the end of the PHE. And as I was listening to that conversation, Sherry, I thought, how many agencies are running around with their hair on fire trying to take care of patients and everything else? To me, it's like, well, if they got to give me 60 days notice, I'm pushing that way down the pipeline until I got my 60 days notice and then I'll figure it out. Um, but I really think there's some value in at least kind of evaluating what some of those changes may be. And it seems that the discussion is coming around two big points. One is the issue of who's doing the admit. And the fact that right now with the waiver, even in cases where nursing is ordered, therapy can do the admission. Now we know that OT's involvement in the admission process has moved from waiver to rule, and we know that in therapy only cases going forward, they can as long as they're in there with PT or speech. But we know the waiver situation allows therapists to admit even in the case of nursing. And so there's some discussion in agencies that have really leaned into that to manage their staffing shortage concerns with nursing. What would that look like when that's gone? Because that will be one that eventually ends. That has not been changed in regulation or conditions of participation at all. So it's been interesting that agencies that have embraced that and really utilized that, now we're going to have to think about how do we pull that back at some point. And then there's agencies, and Sherry, you and I have talked to some of them, that even though it is a waiver, never went that route. I mean, we still are talking to people that can't get the therapist to do an admission that is a therapy only admission, let alone do ones where nursing has been ordered. But I think it's worth a thought about if we've been doing that, what would that look like when that goes back the other direction? And I'm not saying, hours and hours of strategizing meetings, but really just kind of having it on the leadership radar. And the other one, probably a bit more in some agencies, is telehealth. Now, we've talked on several of these in the past about telehealth, and I know we have some questions about telehealth today. But in terms of the ending of the PHE, the ending of the PHE wouldn't be the end of a telehealth option, but it would stiffen the requirements around it related to HIPAA. Because right now we've been able to use a variety of methods to communicate with our patients during the PHE that technically don't meet the HIPAA requirements right now, but the waiver has let that kind of go for the sake of getting patient care taken care of. So agencies have become, comfortable using things like Zoom and FaceTime to communicate with patients. And What I have to remember too, Sherry, is that there are clinicians in this space who came into this during the PHE, and so what's going on right now is normal to them. This isn't even a waiver, this is just normal. And we're going to have to look at that and say the value we've seen in using technology to interact with patients when the PHE is over, what are my options going to be? Because things I've come to rely on could get me into some serious trouble from a HIPAA standpoint if I continue to use them past that endpoint. And I'd
Mhm.
hate to say people say when it ends, we're just going to stop doing it, because I think there's a lot of value in that. But I think it's going to be kind of, again, on the radar about how much have we done with the therapies doing admission? How much have we done with the telehealth piece? And what do I need to at least be thinking about when this ends, so it's not such a dramatic, oh my gosh, yet not another sky is falling moment, when those things are phased out.
I think that's a great statement, Cindy. And again, we do not have any inside information about
No.
whether the PHE is gonna end at the next marking point, but it's some things that you want to think about, especially if you have newer clinicians in the home health space. And that takes me into one of our questions that was pre-submitted, Cindy. If it's my and the questioner asks, it's my understanding that these visits are to be written into the plan of care. Can you confirm and give a source for this or provide the correct info?
Well, I think, anything we're going to be doing with our patients should be in the plan of care. And I know that feels weird because we've always kind of built this around the standard template of, frequency and duration, and then we list the interventions and we list the goals and all of that. But what I'm seeing is, statements in plans of care about the option of using telephonic or telehealth related technology to assist with patient management. I'm not seeing ones that say, we're going to do telehealth visits 2 week 4 or anything tied to that. But it's an acknowledgement so that the physician is aware as well that those technologies may be used to enhance the interactions with the patients. So can we find where it says, the specificity of a telehealth order? I have not been able to locate that necessarily. I'll keep looking, and if we come across it, Sherry, you can put it out in a blast.
Mhm.
But I am seeing think about it in the reverse. If I don't put it on there and now I'm just making phone calls and whatever to the patient, it's nowhere in the plan. So it seems that having it mentioned in there as a possibility does create a more complete picture for what we intend to do, and that the physician is aware of this.
Exactly. And I think that, we need to be really clear that telehealth is not currently reimbursed in the home health space. It is reimbursed in the Part B and in the outpatient space. Any of the Part B providers and physicians can do telehealth up to a certain amount. And they've really laid out the parameters of those
Mhm.
kinds of things. And there's some remote therapeutic monitoring that's occurring with outpatient clinics that is a billable service to some level. Is this something that could possibly come into home health eventually? Absolutely. But however, we've always done telephonic health with our home health patients. We've always done phone calls to check up on their understanding of a medication in between visits and those kinds of things. So this is not a new service per se, but it is a new thing since the pandemic that it's actually being paid for in some of the other Medicare areas. So just stay tuned to the telephonic and the telehealth because it is a great asset, in my opinion. And Cindy, I think you agree with me. It's a great asset in the fully rounded care of your patient, especially those that want to stay at home and want to make sure that they're getting all the information that they need. I think that it's very valuable.
Well, and I think we see that, we'd love to flip a switch and CMS say, okay, this is the dollar value we would give you for telehealth. But we see movement in that direction even more so in the proposed rule for 2023 with the idea of establishing G codes specifically to this type of care. So I know as an industry we go, well, that's great. I'm just putting it down. It's not like I get paid anymore. But I think that utilizing a specific code, evidence in the care plan, clear documentation of when we have these interactions. Because Sherry, I believe, yes, we were always making phone calls to patients. Did we write that stuff down? I'd argue a bunch of times no. So we're kind of at that impasse of we want the money to do it almost first, as opposed to, okay, this is what I've been doing already. See, it's in my plan. Yes, I like the G code idea. We have information now on the claim that this is occurring to make the case that this is not a one-off. This was not just because of the pandemic, and this is the value we see to our patients to be able to continue with these things.
And we would also highly recommend that you go ahead and write a policy and a procedure on your home health
Hmm.
visits. What should happen around them? What are some of the guidelines for your clinicians? And be prepared that if this does become a paying service, that you are ready. The value is there whether it's paid or not. However, if it once it does become reimbursed, and I'm being positive about that, you want to make sure that you already have solid policies in place so that your clinicians and and your staff can start, hit the ground running in providing that as a paid service. Second
Well,
question.
Sherry,
Go ahead.
real quick, I think though it also helps to create consistency around this kind of care. I know there are some agencies that for scheduled like phone visits or phone check-ins, there's a template of what you're going to ask in the EMR. So it's not kind of, hey, call your patients and I
Yeah,
guess, you could end up talking about the dog for 10 minutes, which, is good for building relationship, but not really the purpose of this call. So I'm seeing more that have created a phone template so that when that call is made, the clinician is able to do that. And I know clinicians will say, oh my gosh, I got to document more. But again, it's acknowledging this is time spent. This is what you learned. This is what the follow-up is. So it isn't the whole kind of, well, I did phone calls from 2 to 3. And we've always struggled with that, like, do we know that that happened? What was the result of that? Were they really just sitting in their car? I think this gives us some structure to it that we can start to see what is the impact if we look at outcomes with patients potentially, where we can go into our own data and say the outcome was better for folks that had these phone visits than ones that did not,
that's
potentially.
That's a great point. As we're going into the data collection in 2023 for value-based purchasing, we need to start looking at those kinds of things and what is efficacious for those patients. Okay, I have a skill question, Cindy. I love these skill questions. We have a home health patient that is seeing us for 2-layer wraps 2 times a week per provider's orders. Patient initially has venous stasis wounds to bilateral lower legs, but they've healed. They've discharged this agency has discharged this person previously, and then the wounds return. Is would CMS consider 2-layer wraps a skilled need even without open wounds?
I'm not sure it's the granularity of does CMS have an official position on the coverage of 2-layer wraps as much as it is, does it take the skill of a clinician to apply those wraps? So when they're on and the wounds heal up and then they're discharged and the wounds come back, is it really going to require mostly a nurse to continue to go out there twice a week and do that? Or can someone else be taught? And that's always the issue when we talk about skill is sometimes it's like, well, if we don't, this will happen. But does it really take a nurse to do that? Does it really take a therapist for this follow through on the program? Or have we really just not thought about what are our other options? And if this situation potentially, the person that they live with isn't able to do it or doesn't want to do it or they don't live with anybody, I think these are cases where, bringing in a social worker to ferret out other options. Is there someone from a local volunteer group? Is there a neighbor? Is there someone that could be taught those wraps or to follow up on those wraps? Because if someone else can put them on just as well as a nurse can, and there's no wounds to monitor at all, just make sure you keep these on. It's going to be a hard sell to say that skilled nursing services that could go on indefinitely.
100% agree. And again, does the patient have a need? Do they have, arthritis? Do they have disability of reaching their lower extremities? There's a million different things that you have to look at and say, kind of a checklist of what they can and cannot do, and be very clear about why it has to be that home health nurse to go out and assist this patient. Kind of goes along the lines, in my opinion, of a catheter. Many people cannot change their own catheter. There's reasons for that. It's a infection control. It's a number of different things, and that has been ubiquitously known as a skilling service in home health. This is one of those gray areas. There has to be extenuating circumstances. to continue this patient with active home health to provide those kinds of dressing changes. And Cindy, there's a lot of things that need to be explored as far as technology and other things that are out there besides these types of dressing, correct?
Mhm. Yes, I mean, again, looking at sometimes it's, well, this is what the doctor ordered, and I know that there's other things that can be tried, but again, we really need to look at it through the lens of what are our options from a dressing standpoint? What is a way potentially we could achieve similar results, maybe with a different approach? And all of that, problem solving would be skill. I mean, that's what you're doing is you're trying to figure out a way to better manage this individual. It could also potentially be that you do find someone who's able to do the wrapping, but they still may be, depending on the circumstances, skillable under M&E in terms of someone else is doing the wrapping, but the job of the nurse then becomes to oversee this
Mhm.
and make sure that this is effective. And it's not like, oh, wait, the neighbor kid could wrap it. He wrapped it once, discharge. I mean, you'd want to make sure that this is, over time it's achieving the desired results. So I think there'd be an opportunity as well to consider an M&E route for this individual as opposed to just kind of in the we go 2 and 3 times a week and wrap and wrap and wrap and wrap and we just are going to do this forever.
And if you choose to go the M&E route, just remember that there's different codes that you have to bill. And
Hmm.
talking about maintenance, we could start a conversation about maintenance therapy and M&E in the home health space. And if you know K&K, we could talk about this until next Tuesday. So we don't want to do that, but we do have another maintenance question, which I thought would flow right directly into this one if you're okay with that.
Yeah,
Um,
sure.
uh, uh, this person listened to some of our information on maintenance, and we've actually gone to their company to teach about maintenance. And the question that they have is, can patients on maintenance still have a home health aide while they're receiving maintenance therapy?
The short answer is yes. I mean, what we have to understand is that maintenance therapy is simply an approach to care. It's not a different kind of therapy. It doesn't have different, issues related to if they're a home health patient and they're getting maintenance therapy and need an aide. Yeah. Do they need a social worker? Potentially. Can they get a social worker? Yes. Can I be providing maintenance and a nursing need arises and they need to have a nurse added? Yes. Any of those other services that are part of the Part A benefit, the skill of this being the maintenance therapy, yes, the aid, the social work, if necessary, can absolutely be added to the plan of care.
Excellent. That was, I think when I found that question, I did respond with a yes. And it is very simply a yes.
Mhm.
Now, wondering if we have another question that just came in about telehealth. Is we're busting a myth here. If telehealth is or is not allowed in home health, and if you're considering using an evaluator, a PT or an OT, for a telehealth evaluation with the PTA or the OTA, what would be the case? They're seriously short staffed and they want to be able to evaluate via telehealth. Can you just give your thoughts on that, Cindy?
Well, and this is where, I want to make sure people understand. We call it, K and K Q&A. Yeah, that is going to stick, Sherry, because I do like how that sounds together. Um, doesn't mean K and K has all the A's. We don't necessarily have all of the definitive answers. If we need to go back based on a question that's just presented to us and dig a little deeper, we're happy to do that and share information later. My response to this one isn't really a definitive answer as much as it is a concern that I would have. And this isn't the first time I've heard this kind of question about can we have, the PT or the OT do the evaluation remotely and then the care is going to be provided by a PTA or an OTA. So it's like, so in other words, I'm going to do my remote evaluation as a PT and then not see them until whatever required reassessment comes later. I've been redirecting folks back to their state practice act about
Mhm.
this because I think this is more than whether or not it's a billable visit, because we know a telehealth visit isn't billable,
Right.
period. But to establish a plan of care and then someone else, not you, is going to go make the next visit and carry this out. I just have some concerns that I haven't found a resource that I can shake my concern. That I'm not sure from a practice standpoint, that actually works. Now, if someone's listening to this and knows and has the magic source for that and wants to share it, I am fully prepared to be enlightened. But there's just something about it, Sherry, that I wouldn't be comfortable as a PT going that route.
I agree, Cindy. And as a former agency owner, all I think about this is full of risk, right? And we always have taught our start of care clinicians, whether it's a nurse or a therapist or anybody else, and what an evaluation is by essence is the start of care of that discipline. We've always told them that that really should never be done interview style, correct? We've
Right.
said that you actually need to get the patient up and move them around and see what they can and cannot do. I'm not sure that I fully could understand how a PT or an OT could assess someone's ability safely remotely. And that concerns me. We are a hands-on profession. We're a do manual muscle testing, assess for balance, assess for things like that literally could put the patient at risk. And I would make a recommendation. I feel comfortable making a recommendation that this is trying to take some corners off the square box of compliance, and it's definitely taking the corners off a square box of risk. It is a way to try and speed things up and get these services to a patient. But I'm very conservative when it comes to taking risks, especially in home health when you're not there all the time, unlike skilled nursing or the hospital. That a person is going to be considered and deemed safe via an interview that's telephonic.
Well, and there's been some discussion too about, well, what if the PTA was physically present and the PT was remote? And when you
Well,
said about muscle testing and things, I thought, how would you? I'm not, and again, I'm a PT, you're a PTA. This is not a PT PTA weirdness. This
yeah.
is the manual muscle test, and many of these things is a judgment call by the individual. And I'm I'm not really assessing it then if somebody else is and then telling me what they felt or what they saw. Now I'm not just interviewing the patient, I'm getting information from someone else.
Right.
And again, you're right. I just get stuck on the fact that is establishing the plan of care for that discipline. I don't know. I just it does feel like it creates risk in terms of my responsibility is to establish that care plan. And yeah, other people can follow it, but I don't think I could do it that way.
I would actually feel more comfortable with the evaluating clinician going out and doing the in-person evaluation and then maybe using some of their other visits, even though they're not billable visits, to do telephonic visits once they've actually seen the patient in real time and know what their risk level is. I think that that's a better way of looking at saving time versus doing that with the start when the patient is unknown.
It
Um,
just popped in my head, Sherry. Early on in the pandemic, I did a decision tree thing with Dr. Jason Falvey when there was the discussion about triaging patients, about in-person eval, who could potentially wait. Maybe that's something I need to pull back out and you can look at for maybe a blast, because I think that fits kind of with the decision, and overwhelmingly it came to a in-person eval. I
right.
mean, the use of telephonic after was, what the decision-making thing was trying to assist with, but all roads went to body in the door for that initial assessment.
And body in, not just body in the door, but body in the door as soon as possible.
Correct.
Right? Because there was a disconnect if there was a show of decreased outcomes if there was a delay in them getting that service. Am I mixing two studies up, Cindy? I think that those were
Yeah.
together.
Well, no, I mean they weren't concurrent. They have a relationship. I mean, because
Okay.
also there's been discussion about, delays in receiving therapy leading to less than desirable outcomes. But it's a similar conversation where the amount of therapy provided has a bit of a ceiling effect from an outcome standpoint, that to to automatically say lots and lots of therapy makes you even better isn't necessarily materializing either. There's almost like a sweet spot at which the therapy got you where you needed to be, and this is a reasonable time frame in which to discharge it.
Yes.
Not a formula, not like a checklist, but
Yeah.
the idea that more therapy is always better, and this has nothing to do with PDGM. This has always been just because 20 gave you more money, giving everybody 20 didn't necessarily get you better outcomes than having some of those patients done sooner.
100%. We have another therapy question. We get a lot of therapy questions, as you guys might imagine, but I want to remind everyone that if you have any questions that have come up while we've been talking, please use the Q&A box and submit your question, and we'll get to as many as we can. This one is about PT OT treatment with documentation. Several notes for the PT and the OT are showing that they're both working on bed mobility, transfers, and balance on the same patient. The questioner has concerns about Medicare billing to make sure they are not duplicating services. If both are documenting working on balance, however, each is specific to their goals, OT working on standing balance for ADLs in the kitchen, etc., and PT working on balance to improve functional tug scores, MCT, SIB, etc. Would this be okay since they are goal specific as long as the documentation supports? Same with transfers, as my OT are working on transfers with some specific carryover to function to improve transfers for the bedside commode, the toilet, the tub, etc. So I think what they're asking is if both clinicians are documenting working on the same overall skill, the overall umbrella skill, is this something that they should be concerned about when billing to Medicare as being a duplicative service?
Well, I think the key phrase in there was in the documentation. I mean, here the devil's in the details. Because if it looks like what far too many notes I see, if PT's putting transfer training and OT's putting transfer training, and that's about it, that could very easily be interpreted as duplication of services. But we have to think about the context of what specifically is being done for that individual. Why is there a problem with said transfer? And then, like you said, how is it tying to discipline specific goals? I'd like to use a different example to kind of highlight that point, Sherry, because there have been times between PT and OT, there's been a battle over who owns ambulation, right? That, if OT documents ambulation and PT documents ambulation, it's going to be duplication of services. And I've always been like, okay, if the way I document gait training looks like how OT is talking about ambulation, then I'm probably not documenting in enough detail as the PT. Because the idea that OTs should never ever document the patient walked anywhere is ludicrous. I mean, how do they get to the bathroom? Are they flying? Are they rolling? Are they jumping? I mean, yes, they do walk during an OT visit, but the depth of the information specifically to gait deficits and impairments and balance and how all of that affects that detail should be in my content, and my content isn't going to be made better by telling OT to never document that they walked anybody anywhere. So it's really about not just, kind of superficial documentation that very easily, like I said before, can be seen as duplicative, is why am I working on it as it relates to my discipline specific goals? But this is where I want to continue my gait ambulation issue. I've also seen at times where OT kind of goes over that line, and now I'm seeing visit after visit of this functional mobility training. And it's like, what are you doing? I'm not seeing ADLs now. I'm not seeing, how they're accessing the bathroom or the kitchen. It's just giving me distances or time of repetitive functional mobility training, which just sounds like you tried to reword ambulation. That I think is a problem, because if I'm seeing PT doing gait training in detail with this individual and OT's walking them a lot, but I don't see any connection to ADLs, then again, it is very easy to interpret that as duplication of services, because I'm not seeing where your functional mobility anything is tied to the ADL you're supposedly working on.
Mhm.
And that's where I think transfers sometimes we have to remember that is an extremely broad idea of transfer training. I mean, there's multitude of transfers, and it's tub, shower, it's toilet, it can be bedside commode, it can be getting in and out of a chair, on and off the floor, in and out of a car. We just need to make sure we're talking about which ones, and how, again, that fits to the functional relevant goal we've developed with the patient for our particular discipline.
And don't forget that a person has to be able to get to the face-to-face appointment, so they have to be able to get in and out of their car. They have to be able
Mhm.
to get up and down from a standard height chair. Many of them are in their homes where they have a raised seating surface or a seating service that will assist them getting from sit to stand. Those kinds of things are super important, and it goes with what the guidelines are for home health currently. I had a follow-up question to that,
Oh,
Cindy,
before
because
we go though, Sherry, because what I would like to know is your thoughts on what has happened to the recovery off the floor part of fall prevention. I mean,
right,
I remember when it was very clear that we weren't going to like go around and push people over. Please, that's we're not doing. Hey, okay, boo, you fell down, get off the floor. But to teach people how to safely get back up off the floor, should they have a fall occur.
right.
I I don't see that. And I mean, unless that's what's buried in the term fall prevention education, I don't know. But I would challenge our listeners to really think about, for our patients that, especially ones that we have, where they know that they've fallen and it's likely that this will happen again. Have we taken the time to build in a care plan about how would you get back off the floor? What would you do if you found yourself there? And whenever possible, safely having the patient demonstrate that. I mean, how many of our patients or just people in the general fall, panic, don't know what to do, injure themselves further trying to get up in some convoluted way, or lay there waiting for someone to find them, and sometimes with a terrible outcome. So I just, the talk about transfers, just something that's been bugging me lately is what happened to that part of dealing with falls, because I rarely, if ever, see that documented anymore.
Yeah, me neither. And that's interesting because that back in the late '90s, early 2000s, we were all setting goals towards floor transfers. And again, I'm not seeing that goal even set
Right.
anymore because but that is super important in showing people that there are techniques that work, even in a case where there's decreased strength and decreased range of motion. And there's also, devices that can be used in those situations, like call alerts, and or reaching out to the local EMS to come out and help assist somebody from the floor if they're not going to be safe attempting to get up from the floor. Those things are super important. But I wanted to kind of stick in a question here, Cindy, that's been coming up quite a lot. It's about, with the staffing difficulties, particularly for nurses and home health aides, we're getting a lot of questions about whether or not OTAs and PTAs can perform baths and or aid services. What are your thoughts on that?
Well, as a PTA, would you like to start the thoughts on that?
I would. I have no problem personally as a PTA assisting my patient with the bath if it's in the functional relevance of the plan of care that I've been provided by the PT. I think that we are all held to our license and held to the limitations of our license. However, as a PTA and as an OTA, the only person that I can take orders from is the PT. And I think that sometimes when agencies start having other disciplines cover for services where we may not be staffed as adequately, we have to understand that we cannot take those orders from the agency. And that's my concern is having, a plan of care and competencies and other things to do these other services.
Well, I'll ask you a secondary question then, Sherry. What are your thoughts when people say, well, I'm just using them like an aid, so I just put it in as an aid visit, and they're just substituting for the aid. So it's not really the therapy plan. I'm just putting them in as an aid.
I don't think that's appropriate. I think that, I'm not trained as an aide, as a PTA. There's a lot of things that aides are trained in and have competencies and education on that I might not be privy to. And what the limitations of the aide are, what they can and cannot do in the house, is probably less than what I can do as a skilled clinician. So to me, that's problematic. I would think that you would have to formulate the plan of care through the appropriate supervising clinician and have that be part of their plan of care to cover the necessary elements of your state practice act.
I would like to just kind of add to that because clearly the staffing situation in many organizations is extremely tight. And so when we're looking at, the patient's need of aid services and the therapy role in that, I'd like to just kind of push that a little further and say, how closely are we, monitoring the aid care plan? Not, I understand, we have to write it and the supervisory visit and all that other stuff, but I'm talking about the tendency to write an aid care plan at the very beginning that is providing a considerable amount of assistance to this individual because at that time they need it at a potentially higher intensity because of this situation, but then it doesn't appear to ever get revisited.
Right.
And it's going to run the whole episode without a change. So I think sometimes what I've seen successful in these situations is the referral to OT, and actively engaging OT in the oversight of the aid in terms of backing down how much that they're doing for this person because the person doesn't actually need that kind of help anymore, or adjusting frequencies because they don't need that intensity anymore. I think sometimes we're looking to substitute people in to maintain the aid frequency when maybe that doesn't need to occur that way, or the visit doesn't need to be as long because they don't need as much help anymore. So I think there's a way to incorporate some oversight in that to more strategically use the aid you have as on top of, dealing with the rest of it. But I think sometimes we just look at how do we keep doing what we've been doing and try to put somebody else in there, as opposed to could we be a bit more strategic in how we use the aids we have.
100%. And I just want to be clear that we're also getting feedback that there could be home health agencies that are not providing home health aides. That is a very risky thing to do. If you home health aides like social work, like PTOT, speech, and nursing, if you do not have one of the five skilling services in, and I say five, it might be six. Now, as soon as I said five, I thought, oh, it's six, isn't it? If you do not have one of those services to provide to your patient and they need it, it's not okay to just say, "Oh, well, we'll just have somebody else do it," or we'll tell the patient that we don't have it. You are obligated as a Medicare home health provider to refer them to an agency that does have that service. But we're hearing that there's some practice of not providing aides and referring them to private duty care for their aid services. And just to let you know, that's very risky. And we have some authoritative knowledge on that. We've asked some of the folks at Palmetto this question, and it is very risky and it's something that is not appropriate. So if you have any other questions about that, please reach out to us because that's something that when we heard it, we both kind of went, "What?"
Well, I think there's two pieces to that, Sherry. One is clearly if I'm trying everything possible to provide a service, and where I've seen this reach desperation levels at times is like a speech therapist. I mean, there's like five of them in the country that do home care, and we're all trying to share them. So there can be periods of time you don't have one. So if a referral comes with that need, we know that we have to disclose we don't have it, and that they have the option of choosing another provider that does have that, and we try to facilitate that, which all feels good. Where it gets weird is the piece I think you said very quickly, and I'm not sure people understood. There are growing pockets of home health agencies that are dealing with this, intentionally not hiring aides and then referring folks to private duty to have them pay for the aid. Um, the aid is a part of the Medicare Part A home health benefit. So the route of, I don't have any, I disclose, I help you find another home health agency to take care of this is fine. The I don't have it, so here, use them where you have to pay for it. Yeah, that's how we ended up talking to Palmetto because it was like this has an extra like uncomfortable feeling to it, and I'd like to know what they had to say. And they didn't look too happy that that kind of thing even occurred.
Right.
So yeah, I even if you're like, oh, I would never do that. I don't know anybody who does it. It is occurring, and we know that sometimes the bad behavior of a few tend to make new rules and regulations that torment the rest of us.
100%. And that's, that's as far as I feel comfortable talking about that. I would
Hmm.
suggest that you speak to your fiscal intermediary, whichever one it may be. And if you have a question about whether or not this is available, then if this is appropriate care and appropriate plans of care, then that would be taken up with your fiscal intermediary. I'd be very careful about that. Okay, recently, there's another question. Recently, we were contracted by the local hospice to provide a PT eval on a patient that was in a SNF or long-term care. I was under the impression that as a home care, we are not able to provide services inside skilled environments. If we are contracted by hospice, is this permitted?
Technically, yes, because I think the questioner intermingled two issues. You are correct that a home health provider does not go into a skilled nursing facility. Hospice is a different story, and could be involved within a skilled nursing facility. So I think by being someone working in traditional home health, that felt very weird, and I totally understand why it would. But you were not going in there as a home health provider, you were going in there under hospice.
Right.
My favorite part of that question, though, is yay, hospice ordered therapy. I'm not saying, that this is a shameless plug for that, but for years I've struggled with the lack of therapy evaluations in the hospice population. I know that they're not, you know, restorative patients. They're not in there so we can get it better. But I remember, Sherry, very early on in my home health career, sitting in case conferences with hospice, and they would be talking about, this patient that kept falling and falling, and the wife was distraught and they kept falling. And I'm like, why would you not order a therapy evaluation? Oh, because it's hospice. Um, Therapy can be provided under the hospice benefit. It's not going to be in the same manner we would expect it under restorative or maintenance in the home health side, but it can be extremely valuable in troubleshooting issues like falls, like difficulties with transfers, to enhance someone's quality of life through caregiver education. It can be a huge positive. So that was my excited part of that question, Sherry. I'm like, yes, somebody got the order. I was celebrating that piece.
As me as well. And remember, anytime that you're offered these opportunities to do evaluations for other levels of care, that you probably need to have a contract involved. There needs to be a contract that, states what your clinician is going to be doing and what reimbursement you can expect back. You cannot bill those evaluations under your current home health. And if they're on hospice, they're probably not under your current home health. And there is no obligation of these other payers to pay you unless you have a contracted agreement. So definitely make sure that you have all that in place before you send your clinicians out to do other services that are not traditional for your home health. There's a couple of comments that have come in through the chat, Cindy, and I wanted to mention these because I think they're fantastic. Thank you guys for participating. Many of our patients are significantly heavier, some dangerously so, in relation to 20 years ago. So floor transfers are no longer safe for one clinician to address. Can you address that real quick, Cindy?
I mean, I think that, okay, first of all, we were not saying that every patient should be put through a floor transfer. It does need to be looked at from a safety standpoint. And if we are faced with an individual where it is no way possible that if we got them to the floor, we could get them up without significant risk to ourselves and them, I would not put that in the care plan. I would potentially address that another way. Is there a way, with the caregiver, between the two of us, could we do it? Is there a safe way? Or is it going to be the realization that the education now shifts to, if this individual ever ended up on the floor, maybe my strategy now is to tell the caregiver not to try to pull them up, because we've seen caregivers injure themselves in well-intentioned, I can do it. And it's like, okay, let's look at the situation. This person goes down. You really have no business trying to get them up. So it may be more of, how could you position them so that they're more comfortable, get a pillow, that kind of thing, that we may just take for granted and say, well, obviously I would do that. Well, in a panic situation like that, people might not think through those steps. But here's what you can do to get them comfortable, and then you're going to have to call for help. Please do not attempt to get them up. Even if they start hollering at you to help them get up, it's really not safe.
And I'm going to talk about some next level graduate school scheduling and logistics. Is there a possibility that you could coordinate where, if they're receiving physical therapy and occupational therapy, that at the end of one of those visits, there is a tandem attempt to train or to see if this person is able to be moved appropriately and safely? I know that coordination sometimes can be daunting, but it is something that is available to us in the home health space, and or using the aid to assist in those situations. Those kinds of things can happen, but more importantly, it's the safety of the patient, and it's the education around floor transfers that we've seen become completely absent. And maybe the goal would say something that the patient will remain safe in the event of a fall to the floor, and address that goal. And is probably a better way of putting that. Is that something that you would think could be appropriate, Cindy?
Yes, and like I said, it could also be education to the caregiver about what not to do in that situation.
Yeah.
Because I still remember many patients where the patient themselves was very large, and I was concerned about transferring them myself in case something went wrong, and guaranteed their caregiver was usually some itty bitty person
Yeah.
who'd come out, and you're like, oh my gosh, okay, so if this person starts to lose it, how do you safely get out of the way? Because if
Right.
they fall on you, you're probably going to get more hurt than them.
Right.
But a lot of times, there's that dynamic of the caregiver as well. So I think there's different ways to approach it. But at the end of the day, I would not suggest out there by ourselves, we take someone we know we can't get up safely and say, well, this is part of our care plan, and put them on the floor.
100%. And instead of putting them on the floor, consider putting them on the bed and having them see if they can
Mhm.
get up on their knees on the bed or on a couch. I mean, there's services that you can practice some of the elements of a floor transfer without putting yourself at risk. I think that that's something that we need to think about.
Mhm.
And the second statement that was made is the state of Michigan has apparently put language in the state regs that for therapy only cases, the home health aide must be supervised in person by the therapist. And they asked if we were aware of this regulation in Michigan, and is that an accurate interpretation?
I am
And-
not as familiar with Michigan rules as I used to be when I used to be licensed in the state of Michigan. Um, that they need to be present. I'm not seeing a lot of states where that is the case, but Sherry, we can dig into that a little bit more.
Yeah,
But we do know if that is on the books, yes, that is more stringent than other rules, but we're always going to be held to the most restricted version. So
yes,
even if we would say, well, that doesn't say that, Medicare doesn't say that, okay, but Michigan says it, then we would be held to do that.
yes. And that's the thing. That's a great reminder, Cindy, that we're held to the stricter of the guidelines from the
Mhm.
state to the federal rules. So and or your policies and procedures. So please don't write your policies and procedures any more stringent than the state or the national, or that could get you. You could kind of hit yourself with your own stick, and you don't want to get in that
Mhm.
situation. Um, on that note, one of the things that we do at K&K is we do a lot of quality audits for agencies. And the question came in, what percentage of notes or charts should my QA department be reviewing on a monthly basis?
Well, I think we'd have to separate that out a little bit in terms of what QA activities are we talking about? Are we talking about a complete soup to nuts type audit? Are we talking about spot checking coding or OASIS reviewer work? Are we talking about a specific discipline? I think to me, and Sherry, you're right. We do a lot of these. We do not base our sample size by percentage. We take it by what starts to emerge a trend. So when an agency says we want you to do an audit of 5 charts, I'm usually very uncomfortable with that because that's hard to say I'm seeing a pattern in 5, especially if you start looking at the findings and saying, well, 20% of them had this problem. Well, that was only 1 chart of 5. That's a little small. What we typically see is in that 15 to 20 is the sweet spot where you can really start to be able to identify this was not a one-off, this is happening with some degree of regularity, and we probably need to do something about it. Personally, and Sherry, you can contradict me if you feel different, sometimes bigger isn't always better. It becomes very time consuming to read all those, but once you've crossed a certain point, the rest of it just keeps reinforcing the trend you already figured out.
Hmm.
It becomes just more and more and more of the same, which when we have limited resources internally in agencies to be able to do this, it seems like, is that really a best use? So it comes down to what am I focused on? And then how many of these do I think I need until I see a trend?
Also, as we're starting to really look at our QA departments and try and figure out how we can reallocate some of our experienced staff back into the field, and I know that about 20 people on this call probably just had or on this session probably just had a heart attack. But in the reality of the situation we're in with staffing, it's very difficult justify having an extremely experienced clinician in the QA department not seeing patients when we're trying our best to get those services out to the patients and keep them in their home. I think that we need to understand that there are resources out there, K&K obviously, but there's other resources that can help you with some of these tasks that are taking the time away from that clinical care that you can be providing. I just think it's really important that as we're relooking some of our strategies, that we understand that this is one of those things that you can't just say, well, we won't be doing QA this month because we had to take everybody out of the QA department and put them on the road. That's not good, because that's how things can fester and things can get worse, and you can end up in an audit that you can't defend yourself, and that's not a place that anybody wants to be. So try not to stop those compliance activities, even though you may have to be reallocating your staff. I hope I said that right, Cindy.
You did, and I'd like to add to that because sometimes I think what happens with QA activities is, quite frankly, what is the point? Are we
Mhm.
auditing for the sake of auditing? Are we auditing so we can check a box and says this is what we do? Or are we creating action items based on our findings? Because what's interesting to me, Sherry, is when we're called in to do an audit and then we present the findings. In my 9 years with K&K and 10 years prior to that I've been doing this kind of activity, I have never had someone shocked by the results. They knew it. They suspected it. They knew they had a problem in this area. And I've always felt like, but if you knew it, how come you haven't done anything with it? And I think that's at times where folks that are in the QA role are doing these audits or presenting this information, and then nobody seems to like try to fix it. So we audit it again later and it's the same thing, or
Mhm.
we audit it again and it's the same thing. I mean, the whole purpose of this kind of activity is to either confirm, hey, everything's rocking and rolling, we're good, we don't have to worry about it, or wait a minute, we have a trend here, or we have a couple clinicians that are, and this is what we need to do to change it. That's a piece I think sometimes that, especially when people get busy, goes even further down. I got the audits done, Sherry, we're done for this quarter. And then we did what with it? Because if we aren't really using it to either confirm and continue good processes or fix things that aren't working, they just become worse over time. And
Yes,
then just auditing
100%.
again to say it's still there isn't a good use of anybody's time.
That's right. And you can only you only get changes and sustain things that you're going to be willing to manage. And managing your QA is super important, and making sure that when those audits do come through, because some of them are random. A TP&E is something that is done in an area and it's done for a certain amount of time, and it's so nice when you get a TP&E, if you turn in the required documents or the required charts and they come back and you get a passing grade the first time. That's a blip, but when you get to the third session of TP&E, that can take a significant amount of time and dime to answer. And so that, time and dime out of your agency's productive clinical time, and definitely impacts your efficiency in a negative way. Cindy, before we go, and we're about finished, you guys, the last question was, we know the proposed rule is out. What should my agency do about the proposed cuts? When is the deadline to comment? I chose to add that graphic to this first slide today because we have until 8/16/22. My understanding, 5 p.m. Eastern. That may not be accurate, but 5 p.m. Pacific would probably be something. I don't want you to miss out because you waited till 3 o'clock in California and didn't make your comment. Submit those. There's 3 ways to submit. Any of our blasts are going to include this information until 8/16. This has become a campaign for us every year because we think it's just so important that there are real boots on the ground stories that CMS hears about what changes they're proposing and how it will impact the care. Um, Cindy, do you want to briefly talk about the proposed cuts and what you're suggesting?
Well, I think what's concerning is when this dropped, and people started looking at it, in talking with several professional associations, they were rather stunned at the lack of outcry from their membership. I don't know if we looked at it and some people just passed out from shock, or everything's been so crazy with staffing and everything else that we didn't read it yet. But we're going to have to, because the piece that's really concerning is the proposed payment reduction. And yeah, with the adjustment, it comes out, but it's still over 4%. And there's very clear minds that are smarter than mine that are digging into that math and arguing that CMS does not have the grounds that they claim they have to be able to make that kind of reduction. Clearly, we know the pandemic affected utilization data and different elements of this. But I think in this kind of situation, if we wait and just say, well, the associations will respond or the agency will send a response, we're going to need a lot of responses. And I think there's always been more weight in real life implication responses about what this can mean for patients and their loved ones. And I think personally, Sherry, if we had another hour, I'd go full on rant. I think we need to be indignant about this to a certain degree because the little legislation keeps, going about hospital at home and how successful that has been, and choose home to be the carve out from the skilled nursing facility thing is so wonderful. And all we heard during the pandemic is people were home and they wanted to be home, and nobody wants to go to a nursing home, and everything is so. And you rely on us, dear Medicare. We still remain the least expensive. I heard somebody refer to, if you look at what Medicare spends to hospitals versus us, we're like the change you could find in your couch in comparison. And yet you want to cut us again in the middle of a PHE and everything else going on. So I think we can get upset, but if we sit on our hands and don't comment, they're going to believe that this is okay. I mean, when they get very few comments, there's 12,000 home health agencies. When they get 100 comments, which might seem like a lot, that is very little up against 12,000 providers. So be on the lookout, communicate with your state associations, look at what's going on with the National Association of Home Care. They're putting together resources. Please, let's not just, put our name and use the same form letter all the time, because then they just get the same letter 50 times. Can we tweak it with a real example in your agency, what that would look like to take that kind of cut? Because I'm hearing rumblings that people are running the numbers and say if this goes through, a third of agencies could go under.
That sounds hyperbolic, but it's not. And I just want to be really clear that nobody is exempt from commenting. So having
No.
your patients that are from a generation that is used to being activists and used to working towards getting what they need and want, as a Medicare beneficiary, have them write letters of support for home health. Have them write letters and let them know what's in this proposed rule and how it could impact the care that you're providing them, and give them the opportunity and the information that's necessary to make those comments. Currently, Cindy, I looked on there today, and we're almost 30 days into the comment period. We have like 32 days left, or 33. I think there's 31 days in July. 33 days left, and we only have 33 comments on the books with CMS. Believe us, you guys, it matters how many comments. There were some changes that occurred in one of the years where we had 3,000 something comments. There
Mm-hmm.
were some significant changes that occurred when that many comments came in. So tell one, tell all to make a comment on this proposed rule, and try and set the destiny of where home health is going to be. Make them understand the importance of our service that we provide for patients, and just be counted towards that. And again, don't rely on your professional organizations. Don't just mimic and parrot what your professional organizations are saying. Look inside, look in your agency and see how this is going to impact what you do every day, and how important it is that you have the funds necessary to take care of your patients. So we're at 2 o'clock, and I wanted to give everybody the opportunity to get back to their busy day. And I have our contact info slide up. If you have any other questions or concerns, or if you want to elaborate on anything that we spoke about today, please feel free to contact us via our emails. Cindy's is a little bit obscured, but it's Craft, her last name with 2 F's, and valuebeyondthevisit.com. So, and mine is Teague at valuebeyondthevisit.com. So please reach out to us, and we look forward to seeing you guys next time. The next session will be September 22nd, which is the fourth Thursday in September. And I'll be putting information out so that you can register quickly for that. Thank you for attending, and we'll see you in September.